Okay, we'll make a start, everyone. I'm conscious that we have a fairly packed event today, and I don't really want us to run out of time. So as you are introducing yourselves, just a couple of housekeeping, I guess, from our perspective. So we will be running the session on Menti today, and you have an opportunity to join the Menti session now if you would like, or later on. The interactive part of the Mentimeter is not until later. I'm assuming that you are by now all familiar with Menti, but for those of you who perhaps aren't, you can scan the QR code with your phone or else go to menti.com on your browser. And if you enter the code 71318548, that should get you to the Menti. So welcome everybody. And thank you very much for joining us for the session today. My name is Erica McGuinness and I'm an improvement manager with ESIS, and I have the pleasure of hosting you for this very first learning event in the collaborative series. We hope obviously that many of you will be able to join us live for the sessions, but for those of you who can't, there's always the opportunity for the session to be recorded and you can listen to that on playback as and when you are able to do so. Today's session is about internal professional standards, and we will be looking at that through the lens of human factors. And I have no doubt that this will offer you a lot of food for thought and things to consider back at your respective organisations. I'm joined today by a number of my colleagues in ESIS, and I will just ask them to give you a quick wave, and then they will introduce themselves as we progress through the session. But before we dive in, we're conscious that this is the first session today. So we wanted to just provide a little bit of context, particularly for those of you joining us for the first time, or who may have perhaps not had the chance to participate in the hospital-only discharge collaborative. We are also going to spend a little bit of time just talking about the feedback that we got at the launch event, which was a couple of weeks ago, because one of the things we are really keen to do is to build on the feedback as we progress through the learning events to make sure that we take your feedback and thoughts into account. So as you know, or as you may hopefully have heard by now, the hospital-only discharge workstream is one of 4 national work streams that have been put into place to support discharge, both inside hospitals, but also thinking about the broader infrastructure across health and social care. And the collaborative and the learning events that we are supporting at the minute are predominantly kind of designed around hospitals and therefore part of work stream 1. We will paste an infographic just for people who may be less familiar with the work streams, just to provide a little bit more context in that respect. Next slide, Crystal. Thank you. There are 4 key work streams, and the 4 key work streams have been developed from a review of the improvement plans of the 15 participating organisations. Each of the 4 work streams that you can see on the chart at the minute will be hosting their own collaborative learning events, and we hope that you will have an opportunity to join as many of these sessions as possible. They are all going to follow a fairly similar pattern, but they will each present their own themes and their own opportunities for further consideration. And what we want these events to be is an opportunity for networking across the respective organisations. We all know how valuable that opportunity is, and learning from others and also finding out perhaps what pitfalls and mistakes to avoid is just as valuable. And we hope as well that they will inspire you to take projects then forward within your respective organisations as well. Next slide, please, Crystal. Thank you. We wanted to obviously make our content as accessible as possible. So one of the decisions we have taken is to make the learning events open for all organisations. So although the project perhaps started with 15 organisations in mind, these learning events, so the 16 learning events across the 4 programmes, are going to be open to all organisations. And we hope that many of you will have an opportunity to join us over the course of the next couple of months. The sections marked in green will then be focused perhaps or geared more exclusively towards the 15 participating sites, but there will be lots of opportunity to interact with other organisations across all of the learning events. Next slide, Crystal. So each of the learning events will obviously have its own theme. They will be hosting keynote speakers, so there will be a really broad range of content, which I hope will appeal to everybody. And at the end of the session today, we are really keen to ask for your feedback collectively to help us shape some of the next sessions specific to this workstream, which is obviously supporting operational processes. Next slide. Our learning and content is obviously going to be designed against these 5 key principles. You will have seen this chart before. The principles, again, were kind of driven from the improvement plans submitted by the organisations participating in the hospital-only discharge work, and for us, perhaps more exclusively focusing on those operational processes, which, as we know, are really kind of important to support flow through our organisations. Next slide. There are 3 learning objectives that we have designed, and we've presented these at the launch event a couple of weeks ago. I will pause just for a minute just to give you an opportunity to have a look at them. But one of the things we will keep doing is coming back to these learning objectives as we progress through the sessions, because we want to make sure that by the end, so by the time we come to September, that we will have obviously kind of met them all. Okay, next slide, please, Crystal. And my final word, I guess, for me is perhaps to leave you with a bit of a personal challenge. So as you listen to the next few slides, particularly the presentation and the keynote, have a think and reflect about what you as individuals and perhaps within your respective teams could do differently in the context of internal professional standards. So how can you support these differently within your organisation? I'll hand over to my colleague Ali now, who will just give you a little bit of an update about the outcome of the launch event.
Thank you, Erica. Really, this is about going back to our initial launch, which some of you may not have been at, but just to recap again and looking at how we're going to approach that. This is about focusing on developing the right principles sustainably. You know, what hasn't worked in the past? Why hasn't it worked? We all know what we need to do, but it's the how and what's stopping us and preventing us from doing that. And it's about focusing on that. Richard, again, will talk a lot about that in one element of being the human factors. Looking at the outputs, they should focus on the best pathway for the patient, not the service itself. What would you do for your family? What would you do for your mother? What would you do? What is the best pathway? Looking at it from the patient's perspective and from the patient's experience. It's about those actions having clearly agreed goals and what you should co-designed with the teams and what you expect to deliver. What will those outputs look like? So what actions need to be taken for those outputs? Again, bringing the patient to the centre, reminding yourselves again what hasn't worked in the past and why it hasn't worked and how we can do things differently and what is it that's preventing you from doing so. Saying things once is not enough. The messages must be key. It must be at the tip of our tongue. We must be bringing that into the fabric, you know, of the team, of the project, of what we are doing and making it business as usual. And again, avoid going back to, you know, what can you change today? This is about, you know, using these events as learning and avoiding going back. It's about going forward and looking at what you've learned from before, what the mistakes you made. We said if we do the same thing again and again, we'll get the same output. So it's very much about looking at what has stopped us before, how do we overcome that? And as I said, leading into Richard's talk now, it'll about looking at those human factors of what's preventing us from doing things. So I'll hand that over to Richard.
Thanks very much, Ellie. Good afternoon, everybody. My name is Richard Brownhill. I'm a nurse with a background in ops and workforce planning and more latterly human factors, which is why it's a great opportunity to talk to you this afternoon about, I guess, all of our work, which is incredibly challenging, difficult in the context of how we then make change improvements and do the things we believe in. So if you just indulge me for the next 30 minutes or so, some of you may well have heard of human factors. There's lots of myths about what human factors is and isn't, but it is a professional discipline, so it has its own regulatory framework. It's a discipline drawn from a variety of sources and all the things that we'd recognise: psychology, anatomy. It draws very heavily on engineering. So you'll be aware of human factors and ergonomics fitting with things like the airline industry and major industries. I guess for healthcare, we've struggled sometimes to really put the purity of human factors right at the centre of healthcare. A, because it's very complex, but B, because actually some of this stuff really takes investment in time and thought. But hopefully with some of the insights I share with you this afternoon, we can distill some of the key principles and start to think about how this can help us with some of our operational processes. Ultimately, what we're trying to achieve is how do we improve the design of the environment and what we do to be able to make it easy for us to do the right thing. And I think that's really important. So when things haven't worked before, what does not working mean? When in fact, what we really need is something to help us be better at the things that we know we need to do. Next slide, please. So just again to continue, if you're interested in looking at human factors in more detail, there's a new patient safety syllabus that's quite interesting to look at, and indeed the Chartered Institute of Ergonomics. This thing that really fascinates me is this thing called Anthropometrics, which is you probably don't realise that the seat you're sitting on, or the screen that you're staring at, or the way that you're wearing your glasses or your headset have all been designed with people in mind. So Anthropometrics is around the science of knowing what the right height, the right width, the right leg length for the chair you're sitting on. And you wouldn't think that we put that amount of design thought into things, but actually, if you consider what we do in health, we often don't take those kind of steps. We just kind of do what we can with what we've got. And I think we just need to be aware of some of those realities, but equally think about where we can challenge them. Next slide, please. So it might be useful to think about human factors in the context of processes. And I guess in my career, having been involved in, I don't know, site management, operations, emergency care, acute care, it's been really challenging sometimes to think about that individual or that person or that service. What we need to recognise is that most people working in healthcare are competent and capable individuals. If they're not functioning, it's probably because we're not supporting them with the right things around them, whether that's technology, it's equipment, it's kindness, it's a listening ear when people need it, or indeed, as we've seen recently in the pandemic, just the amount of effort, mental effort we're putting onto people. Healthcare is a complex socio-technical system. That sounds all very grand, but that's where human factors excels, because there aren't sometimes simple answers. What that means is it's really complex, and it means that we live in uncertainty a lot. And I suppose remembering that means that we should try and not be too harsh on ourselves that we can't produce a single answer. So sometimes the evidence is around healthcare professionals that we endeavour to almost design something to the point where we can know it's going to work. And whilst that's a noble effort, I think if you aligned that with improvement and said what we're going to do is test something, learn from it, and continue to design so we're in a closer possible position for it to work, then that is a more healthy setup. The challenge with that, of course, is it takes time, effort, planning, etc. So again, we do need to think about the capacity constraints. It's useful to share thinking on hazards and risks and workarounds. And I was recently in an emergency department watching somebody put a vomit bowl on the reception desk behind a locked door with some medication in. And it was like, oh, that's interesting. And of course, all these things went through my head about, oh my goodness, they breached this policy, they've done that. And I could have gone off like a rocket. Instead of that, I was thinking, why are they doing this workaround? Well, because the time it took for them to go to the locked drug cupboard was so disproportionate that they would break another rule that they had themselves, which was actually we're not going to give the patient pain relief if we don't have something close. So human factors is about balancing risk and understanding risk, and it's really helpful to share our perspectives on risk because we all have a different risk threshold. So really, really useful to think about that, and we'll talk about that later. The other thing is it's really important to understand each other and gather inputs. So rather than saying, I think this, and almost that's immovable, these are my thoughts, is a different way, I guess, of communicating that, but also inviting other people to share their thoughts. The other thing we tend to beat ourselves with is because we're competent professionals, if a mistake or failure in somebody's mind occurs, we again align competency to outcome. and that's not a linear relationship. So we need to remember that actually just because something goes wrong doesn't mean we are any less capable of our professional work. So it doesn't help the fact that we then suddenly retrain somebody because we think that they're not competent. So from a central perspective, we don't necessarily help professionally. So next slide, please. What I thought I'd do is introduce a couple of the core things that are worth thinking about within internal professional standards and ops processes. So someone tells us the site manager's working today, this particular one, and he always gets stressed, so it's just him. You'll have heard things like this. It may not be a site manager, it can be anybody. And what we're seeing there is the risk that me walking into the room who hasn't met this person or who doesn't know who's working today in the site team has this confirmation bias. So I think that they are not necessarily as competent as somebody is describing. And the first moment that person gets to speak to me, I will be looking for the opportunity to say, oh yeah, they're right. They're actually right. They're not quite as on their game as they are, or they're very stressed. As opposed to being kind enough to the person to say, actually, I'm not going to take that into my head. I'm ignoring what you're saying, and that's not very helpful. The other thing we get is cognitive fixation. So I've just, again, had a call this morning where somebody told me that this is the way we're going to do it. I was like, okay, well, that's cognitive fixation. That means I will not be moved on this, irrespective of the inputs that I receive to the contrary. So I think, again, if we have an idea, brilliant. Let's make an idea a fluid thing that we can share, because actually there isn't only one answer. Another comment, it seems obvious that this patient will be fine if they're discharged, so I'll just send them home, or I'll just do this, or this just needs to happen. Well, if it just needed to happen and it was easy, it would happen. So our risk perception varies. One person's perception is somebody else's risk, because we tend to move risk, and that isn't a deliberate thing, it's a recognized technique. And then, of course, we'll have seen this many times, it's not safe to put more patients on a ward if we don't have a bed space. So people will say that boarding or full capacity protocol is not something we're going to deal with here. What we're doing instead is leaving people in the ED. Now, explicitly, people don't say that, but that's implicitly what's happening. And that's not wrong. I'm not judging that person or that system. What I am saying is that's their risk evaluation is. We think the risk is lower to leave people in the ED. We think the risk is more tolerable to leave people in the ED. What we know is all of those things harm patients or potentially harm patients. So if we are in a fixed position where we're saying this is wrong to do this, or you shouldn't bed an SDEC, or etc., actually that's not necessarily a very binary position. We need to understand what the alternative risks are, and you can actually calculate these out. So you could look at all sorts of different ways of being able to calculate risk. So just presenting that challenge in a slight kind of tongue-in-cheek to people. Next slide, please. So let's kind of contextualize this a little bit into internal professional standards, which is one way of being able to look at the world. So I'm going to hand over to Erica now, just to take us through a bit of a Menti piece.
Crystal, is the Menti on the next slide?
That's a no. Well, there it is.
Okay, so if you could all join Menti, we'll go back and scroll through the slides, back again if we need to. So there's 3 sets of questions, and I'll hand over to Richard because I think there's some kind of additional supplementary things he wants you to consider in between one section and another. But I guess if we start from, the easiest point, if we have to consider internal professional standards and why they are important within your respective organizations, why would this be? What value do they add, I guess, to yourselves as clinical professionals or operational professionals? And more importantly, what value do they add to the patient? So something about consistency, And I guess that talks back to some of the principles we talked about at the beginning, that perhaps repeating something once isn't enough, and that you kind of need to keep going around that kind of communication loop time and time again. We've got a question in the comments. Can you all access the Menti? Have you been okay getting on, or do we need to go back to the joining instructions? We'll just go back just to give people a little bit of time to log on.
Erica, do you want to give the instructions of how to do it? Because it might be a first time for some people.
Absolutely
yeah.
fine. Yes, no problem at all. So if you use your phones and scan the QR code, you should get onto Menti. I'll just give you a little bit of time just to make sure you can do that now. I've just changed the settings on the Menti to say that we will move at the pace of the presenter, so that will hopefully give you an opportunity to kind of follow in the same order we are. Okay, we seem to have more people joining now, so that's hopefully a good sign. Okay, so we've got baseline to measure against, absolutely. Flow is everybody's responsibility, and I think this is really important. Flow isn't just the responsibility of kind of individual groups of staff in an organization, and I think promoting or encouraging that sense of kind of collective accountability and collective responsibility is absolutely fundamental to any internal professional standards. They help reduce unnecessary patient waits and provide clear expectations. Richard, any thoughts jumping out that you feel we need to kind of pull out of this?
I mean, I think this is fantastic, really helpful. I guess the consistency argument, we're obsessed with consistency, and I think it's really important, because if we've got consistency and it's the safest process it can be, then that's why consistency is a good thing. I suppose part of my interest is, even if we have consistency, we don't follow that. And the reason for that may be multifactorial, and that's where I'd kind of like to get to in this discussion. I suppose the strive for consistency, ironically, almost comes from taking all of those inputs and that diversity to understand it, to design the most consistent pathway, if that makes sense. Whereas I think what we often see is, and we'll see an example of this, is that we've asked somebody to create a standard operating procedure for X or a pathway for Y, and they've done it in a room at 3:30 in an afternoon for a 4 o'clock meeting, because that's the lived reality. And therefore we've signed it off because it's happened, but the reality is we're not going to be consistent because we've not socialized it or co-designed it. So I think it's really, really interesting stuff coming up here. But yeah, fundamentally, internal professional standards have got to be a good thing. They're about trying to do the right thing, sure.
I liked the comment from somebody that says trusting other people's assessment, and there is a kind of a trusted assessment, I guess, approach here, isn't there? And certainly in the context of, I guess, you know, moving that patient along a journey rather than perhaps repeating steps that may have been completed by others earlier on in the pathway. There is also something, as people have said, about, I guess, clarity in expectation, isn't there? And I guess that standardization of clarity, so that everybody knows what the battle rhythm of the organization is on any given day. Ali, anything that jumps out for you?
What I was going to actually ask was a question here as well, really, Eric, is about everybody being familiar with internal professional standards, and you know, about sharing the resources we have if people want to see other ones to compare theirs with. And I suppose the second question is about how well they're socialized. And as you say, when you write a SOP, it's all very well written on paper, but how well are they implemented and embedded into organizations? And I suppose what those issues are to stop us from doing that.
I guess the test for us to perhaps consider is to go back within our respective organizations and to ask colleagues, isn't it, as to, I guess, how familiar they are, whether they know where to find them, whether they could explain them to others. And if we can't explain processes simply to others, then the chances are they are fairly difficult to understand and engage with, isn't it? Richard, are you happy that we move on to the next slide? I think there's some content for you to share. Crystal, can we move on to the next slide?
Thank you. We've missed out a couple of slides, Crystal. Can we go back? Is that okay? That's fine. Next one then. Perfect. I guess this was just to reinforce the fact that risk tolerance is one of those things that we have to find within ourselves, within our teams, within our organisations. That, you know, on the top left there, parking on a double yellow line, many of us will have done. And I'm not saying that's a wonderfully noble thing, but the reality is we violate or break rules. That's the terminology. Violation, it's a bit heavy, but we do that because there might be a compelling reason, because actually I can see my children from the corner a little bit more closely by nipping onto the edge of that double yellow line. So we trade off all the time. So I suppose it's just injecting that reality. Next slide, please. I just wanted to share a couple of theories with you. The one on the left is a really interesting one. So we see the world through our own lens. So even if you think you're being objective, you're not. You are just seeing the world through your lens, and that's made up of lots of experiences. So if something went wrong yesterday when you discharged a patient at home, or when you asked somebody to do something, that doesn't mean it's going to happen today. But it's really difficult to let that go. We have a self-confidence bias. That means that we generally think we're at least as good as anybody else at doing something. And you see that played out most often on the commute to work, perhaps if you drive, where you see somebody else chopping lanes and you may remonstrate with them, and all of a sudden you end up doing the same thing yourself. So that's not saying we're all breaking rules, but it is saying we live the world through our own eyes, and therefore it's hard sometimes to entertain the thoughts of others, but we need to do that in order to get to some of this consistency we were describing. The other really amazing thing I think that fits that very well with ops, and I recall myself walking backwards and forwards in a corridor one day, permanently by being phoned at either end of the corridor to do something different. And it wasn't about prioritization, it was about the fact that we needed to do something. So this thing called naive interventionism is the need to do something, and we live in hospital worlds very much so, always trying to do something, and almost that no action is therefore bad. That's not necessarily true. Holding your nerve might be really important. Planning for half an hour might be more important than running around the wards and trying to get more beds, whatever that means. And I guess the study done there by Taylor in 2007 was around tonsillectomies, where if you asked the first consultant to effectively go through the patient's notes and decide if they needed to have surgery, you found that they managed to get that number down by 174 to 215 patients. Then you give it to another consultant who took another 99 patients out, and another who took 52 out. So even though the first consultant, who was the most senior, felt that they were in the best position to make that decision, we can't help ourselves but to feel like we want to add value by doing something. So again, you'll experience that, as we all do. Try and think about what value am I actually adding, and should I be considering saying, hang on, am I experiencing, if you can say it, naive interventionism? Next slide, please. I just wanted to say, when people talk about risks all the time, it's unsafe, or it's this, or it's that. Crossing a road is unsafe, sitting on a chair is unsafe, if you want to use that terminology. So it's often used as a stop button. I think when people, what they really mean is, I actually can't entertain this conversation, or I'm really worried, or I don't think we've discussed the risks. That's what unsafe probably means to me when people say it. We do need to get behind it, because actually it's also a tool, a blunt tool for people to say, back off, I can't, my cognitive load is too high. And I don't know whether you know the statistic, we can only remember 5 things plus or minus 2. So on a good day, we probably remember only 5 things, but generally we probably only remember 2 or 3 things. So if you give me 2 jobs to do and I go off to do them, I'll probably forget 1 by the time I'm at the end of the corridor. And remember, in extremis, in an operational sense, we've got 100 other things in our head. So just remember, lots of things bring risk. What we're trying to do is avoid risk, so avoid the consequence and the likelihood of a hazard causing us or a patient a problem. And uncertainty is the space that we live in, and we want to try and improve our risk of vulnerability. Next slide, please. So I just wanted to share with you something I'd alluded to a little bit earlier. And this is a simple SOP for internal professional standards. Apologies, the slide's not quite as clear, but I'll read it through. So patient is referred by telephone, specialty answers call, specialty comes to attend patient within 30 minutes. So that's an example of an internal professional standard. There are many others, like, you know, the shop model for ward rounds and being on a ward round as early as you can so people leave early in the day, etc. But that's a really simple SOP. It's got 3 headlines. There'll be a policy probably sitting behind that is around either internal professional standards or the discussion. I've put a picture of some books on there because usually most policies have got about 78 pages. Nobody reads them. And the reality is then, how do we operationalise them if some poor so-and-so has been made to write this and it means nothing to the people on the ground? So I suppose my question around go back and look at internal professional standards would be, what do they mean to you, would be my question, because I think it's really important to understand what they mean. If we take the next slide, which is the work as done. So there's a really important piece of human factors work done by Holnagel, which is about this thing called work as imagined versus work as done. So work as imagined is I write the SOP saying, pick up the phone, make the call, go and see the patient, job done. That's my internal professional standards written, happy days. The actual reality is patient's referred by a bleep, bleep's answered by 3 minutes by a staff member because the doctor's busy with a sick patient. Staff member's distracted by a relative on the way back from the phone, and therefore the message is delayed and the doctor has to go and find that staff member after walking around the ward. More time goes by. Consultant arrives on the ward and says to the junior doctor, can you come and join me? And the doctor says, if you're lucky, I need to call this referrer back. Now, that's on a good day. What we also know is that there's a hierarchical power challenge sometimes that would say, I'm not going to say no to my consultant because these dynamics exist within our organizations. So I might not even say anything, but if I do say something, I might be very grown up and we've all got a good psychologically safe relationship. And I say, I just need to call this person back. And the consultant says, oh, we don't want to delay the ward round, but I'll tell you what, who's the patient? What do they need? So that's an affable and kind and sensible consultant who's trying to prioritise the work of their service. Unfortunately, because it's a bleep system, and we've not got any patient details because we're going to call the department back, we haven't got any record of the referral other than we know that ED have called us about a patient because we didn't write it down. So we've got some choices. The doctor goes to ED or the doctor stays to finish the ward round as expected. And you can see that that's a binary kind of decision to make. The challenge, of course, is that's an everyday situation. And this is where internal professional standards start to reach their complexity by saying, actually, that doctor is not sat there drinking coffee. What we're trying to do is understand the complexity of how we bring together a socio-technical system, all these different areas, and make them somehow line up to do this consistent thing you're describing. But you can see there already, even at that ward level, we've got some challenges. So what would I suggest looking at this? Well, pretty quickly, I might already say, we've got an opportunity for technology to help us here. Why haven't we got an e-referral system? Because that would give us patient details, it would give us the quantum, how many people, what time they were referred, and whether we can make some decisions around the details on there about whether it's appropriate to break off the ward round and go and see the patient. Or indeed, that consultant and junior may go together. Because if we go with senior decision making, we're more likely to discharge the patient. So I suppose I just wanted to share with you that perspective that says this isn't about people not wanting to do the right thing. We need to try and unpick some of this stuff. And we'll move on to the next slide and hopefully the next question.
Richard, I think you've captured the difficulties that I know our colleagues will face day in, day out there really beautifully. And the simple part, I think, with internal professional standards is probably putting pen to paper and writing whatever standards we may want to, but actually thinking about those standards in the environmental context they are then going to be deployed in is probably where the challenges come in. So I guess taking the conversation further and now reflecting on your kind of personal perspectives on challenges, what are the barriers currently stopping you from delivering your interprofessional standards? there's a good debate already kind of emerging on the chat, which we will come back to as well in the questions section. Yeah, absolutely, being cognizant of the current reality, staffing shortages absolutely play a part in that. Agreeing standards with colleagues, there is absolutely something about engaging early in that respect and making sure people have an opportunity to input into their design. Not enough headspace to think and prepare, absolutely, good reflection there. Another one on workforce. Yeah, reflection on service level agreements. I will do this for you.
I think what's also interesting about this stuff, and I think workforce often comes up, is the so what question, and we'll move on to explore this a little bit further. But I think it is challenging to see beyond the demand and capacity of your service, and so hopefully we'll have a little bit more of a think about that, to understand what the relevant and relative risks are. But it's really useful to tease that out.
Yeah, there's a reference to organizational culture, and I'd like to bring Ben in if he's still with us. There's something about lack of kind of cross-team working, and Ben explains this beautifully in the context of give me patient-centered reasons perhaps why things may not be able to work. Ben, is it worth sharing that with colleagues?
I'm happy to, yeah, thanks. So yeah, Ben Owens, I'm an ED consultant, work with ESIST, and with interprofessional standards, the general gist is not everyone. I see one of the comments about agreeing standards with everyone. You're never going to get the whole hospital to agree. No one's ever going to agree with all the standards. So it's not about everyone agreeing. It's quite a common thing you hear back is, well, I didn't agree these. But if the senior medical nursing teams of the hospital have agreed them, the way I would always present it back to teams who they disagree, say, can you give me a patient-centered reason why not? Because if you do that, you take out that, well, my consultant doesn't want to, or my juniors wouldn't be happy, or you take away that sort of personal opinion, happiness, whatever. Because no, everyone is busy and everyone thinks that they're right. So actually, there is this thing of saying, well, you have a patient. If they give you they might have a really good reason why it won't work. If they got a patient-centered reason, why not? And if that's the case, I think, but it should always be a patient-centered reason why it wouldn't work. On the other test, the other way when talking about them is about the test is always, if your relative was this patient, rather than someone saying you've got to come and do this now, it's your job, do it. Actually saying, if your relative was this patient, why would you not come and see them? What would you say if the doctor wouldn't come and see them? What would you do? If we do it like that, most people go, well, yeah, I would want that person to be seen by that specialist directly rather than via ED, or I want to be seen by a senior doctor, or whatever the standard might be. Most people would want their relative. If they want for their relative, they would want it. And a good test, I suppose, for all organisations, you say, is to how confident you are in your standards. So if your relative, well, ask your staff, if your relative or their relative was admitted to your hospital on a Sunday evening, which is usually a really busy evening, via ED with whatever condition it is, would you send them in the system confident the system would work, or would you phone a friend and say, could my wife, uncle, friend, a child, can you make sure X, Y, and Z happens? If we would phone up and get X, Y, and Z to happen, then our standards and our systems probably don't apply. But the only conversation we should be having here is give me a patient-centered reason why not? Because the standards are out there nationally. People may not like them, but at the end of the day, they're there for the patients. And if there's a resource issue, that's a separate conversation, but it doesn't mean we don't do the right thing for patients. I hope that makes sense.
It certainly does, Ben. Thank you very, very much. Richard, shall we move on to the next slide?
Please.
I think there's some more information you want to share. Thanks very much.
So I wanted to share with you a tool. This is called a Seeps Tool, so Safety Engineering Initiative for Patient Safety. So this has been developed specifically for looking at how we appraise the factors that get in the way. So you can use this to think about designing interprofessional standards. Let's say you can use it to think about a new way of working, or an improvement process, or indeed some learning from safety incidents. So we often will do kind of root cause analysis, and we end up with all sorts of aberrant elements at the end of that root cause analysis. So this is a prospective look, and it can be retrospective. I just wanted to share this with you. I think one of the reasons why I think this is incredibly helpful is we've heard already about some of the normal, sticky, difficult areas of constraints. And the other element is that change blindness, which is something that some guys called Shorrock and Williams describe. They talk about what you look for is what you see. And the idea that what you look for is what you see, if you're not looking for either solutions or design problems or other issues, you often talk about them sat in the coffee room, but you don't formalize them into a process. And therefore it can become a whinge. You're perceived as a whinge, even though actually you're the expert in your area. You're talking about the daily deviation from this consistent standard we're talking about, but we haven't got a platform by which we can project that. So this is the Seeps kind of technological piece around the different areas. How it looks when you map it on a piece of paper is this, if we go to the next slide. So you can use this, and we're happy to circulate this around. Sit with your team on the ward, or sit with your site team, or sit with a few people who you want to look at some of the things you might want to consider as part of your improvement. And what are the factors that get in the way? And these are just the headings from that list I gave you before. So you might think about here, I'll give you an example. This organization in their technology have 3 different logins for their IT systems which don't communicate well. You know, IT and the NHS we struggle with. But if that's the constraint and that's causing the risk, why are we trying to get people to work harder to work around that? What can we do to illustrate that as a risk? And we can quantify again and calculate that. Manual bleep referral system, can't get to a telephone on a ward. So actually, yes, it's a telephone referral, but it's always occupied by the ward clerk during working hours, and out of hours, it's at the other end of the ward. So some of these things are so simple, and I'm sure many of you are going, but I've said this stuff all the time. So this allows us a little bit of a way of capturing those risks to doing whatever it is that we're doing, or whatever it is we're looking at. And really, we're talking about a task or a series of tasks. So tasks might be time pressured. It's really common to find that people say, get the patient out of the ward, get the junior doctors doing more discharge summaries and TTOs. Well, that's fine, but go and interrupt them on the ward when they're doing a really delicate prescription, or they're doing a referral to the diagnostic service, and you increase the risk of error. So we have, and then that bites us back, because we get another initiative saying this is how we reduce the error from something that happened the other day. Well, how we reduce the error is stop interrupting people when they're trying to do their job. So how do we strike that balance, though, that gets us over that feeling of naive interventionism where we want to go, but we're doing something by pushing this person to do? So again, how do we work together to understand that's what's really playing out? Not me being difficult or me pushing, but me understanding we all want to do the right thing for patients and our staff. Because actually, if we don't design this properly around the staff, it ain't going to work. Next slide, please. So it'd be just useful. It'd be just useful for a few seconds just to capture what you think the risks are of not delivering internal professional standards. Where does that kind of leave us in your thought process? Sorry, Erica, to cut across you.
No, absolutely fine. I think the point you made there really beautiful for me is that we live and breathe the world through our own eyes, and that actually it's so important to consider other people's perspectives in some of these conversations as well, to make sure that, I guess, we're taking more all-rounded decisions, isn't it?
Absolutely.
So this is the final question, and then we have some space for discussion in the last 10 minutes of the session.
Thank you for that response. Somebody's living the inconsistency debate.
Ben, is there anything worth sharing from your perspective clinically around risks here?
I think there's risk to the patient, which we're all talking about. I think there's risk to the staff. So as in the pressure, when people don't follow standards, it tends to put additional pressure on other staff and other parts of the system, or it just creates stress because someone else is perceived not doing their job, and that creates stress and anxiety in an already busy system. As Richard says, inconsistency in an already busy system generally causes more work, not less, and also more stress and aggravation. We're all busy and stressed, so that's certainly a big thing. And actually, the main risk is not just the patient. So if someone, for example, didn't see a patient, they refused to see a patient, someone else has to see them, that causes risk to two patients. That person who's not being seen by the person they should have been seen by, but actually, when that staff member is now taken up with seeing the patient that the original specialist should have seen, they're not seeing the next patient. So there's impact on more than one person in this, actually. So it's not just that patient that has a poor experience, actually someone else has a delayed experience. We know that inconsistent systems cause more time wasting. So it's not just one patient who has a compromised experience, it's actually more than one. And in some places you see it when you've got really crowded hospitals and departments. If someone then can't get in because they wait for an ambulance, it's 2 or 3 patients are suddenly impacted by that one decision. So there's certainly the risks in very busy environments actually get higher versus risk on a very calm, quiet day. The risk is really lower. And most of the time we're running in busiest and extremism at the moment in terms of extremists.
Thanks very much. Somebody made a really good point there, Ben, about equity of access across all pathways as well, which I think is important to reflect on as well. Richard, I'll hand it back over to you.
Thanks. I think there's just one more slide, which is probably a summary of Seeps. And interestingly, Ben's just beautifully crafted some of the responses on the right-hand side there. So this is what the complete sheet looks like. That when you've gone through the process with your team or the people you're working with around your task, and that inconsistency and stuff you described, you have a series of wanted and unwanted outcomes, and that's the way to articulate some of this stuff, because actually some of this stuff we want to be able to do. So the teamwork works well. So what we discover is, in spite of all of this stuff that befuddles us, generally we work well as a team. That's a positive outcome, but it takes longer to deliver. And if it takes longer to deliver, and Ben's point about handoffs to other people, we may well duplicate. So actually, when we say we haven't got enough capacity or workforce, we're doing twice as much of the work. The other thing you'll see all the time, linked to my earlier point, is would somebody go to that ward and have a look at X? And that started with the matron. It's now the ops manager. It's now the coup. And who knows, the chief exec might be going next. But there's something here about actually what the unseen part. So if you went into the person part here of the Seeps, what I'd have in that little box is communication, but I'd also have something there around culture. So the fact that if you feel it's so important for one person to leave the hospital and be discharged that you send the chief executive, that's not only an unsustainable model, you demonstrate beautifully the culture of the organisation that says, I don't trust any of you to be competent and capable. And apologies to anybody who's in that position on the call. I think that's the challenge we've got in healthcare, is how do we strike the balance between providing people with the trust and support and design to do what they need to do to deliver the right outcomes, but how do we do that in a way that walks the walk and helps that? And I think the way in some respects could be to involve people like your patient safety specialists, work with some of these human factors elements and try to project that, because actually from a ward to board perspective, people may not actually anticipate that it's not that 3-step internal professional standard, it's that 12-step, if you like, technical rub between all of those elements. And what we can end up with is somebody appearing to drop the ball, and it's then put on that individual who made that choice, as opposed to actually we never anticipated that's what that really meant when we were trying to implement internal professional standards. So I think really trying to design and think and make it real and bringing in the kind of inclusivity and diversity of people we know enriches what we do, using a model like this can really help to pass some of those messages. And as you'll notice on there, staff being exhausted by constant pressure, we'll only continue to do that if we add salt to the wound by saying, oh, it was Jane, she must have dropped the ball today. Well, actually, it wasn't Jane. You probably didn't help her with something that she needed help with. So challenging stuff, but hopefully helpful. Sorry, Ben, I know you're waiting to come in.
No, I mean, yeah, there's just a couple of things that feed in as well towards the end. And I think one of the useful, we don't always, when we've got internal professional standards, it's important to talk to our staff about how to escalate the issues. And rather than going, it's your job, do it, how can we work together to get this right pathway for this patient is a much better conversation to have. there's something about repeating them, as Richard rightly said. You can remember 3, 4, 5 things a day actually, and go, as we launched these standards 2 years ago, well, your junior doctors change every 4 months. And your nursing staff, new nursing staff will arrive all the time. You actually have to repeat them with every induction, tell the staff, repeat them and relaunch them and tell people, because they'll forget, because they've got a million other pathways to remember. It's not because they're deliberately forgetting. So you want people to follow something, you have to repeat it, tell them why you're doing it. And I think the other thing is, when we write our standards, we've got, I think we often write them with an ideal circumstance. If the patient came into ED, they went straight to an assessment area because there's a bed in the assessment area and it was daytime hours and the consultant was there and the physio was there and they were seen straight away. But actually, most hospitals don't work like that most of the time. So when you write a standard, you also need to say, in this, it may be appropriate, you say, in this scenario, this should happen. Well, what we do in plan B, well, if we're running in plan B, we've got exit block, if we're spending in 12 hours in ED or 24 hours in ED, the standard may not work, so you may need a plan B. The time standard should be the same, but how that's achieved may be different. So in healthcare, we often write a perfect scenario standard. What's that? But part of that is escalation. So if the junior doctor is stuck with a very sick patient, we should be ringing the registrar from that team. And people shy away from that. They go, I'd try that, or they ring the consultant from that team if it's appropriate or it's urgent. So something about in those standards, writing in about escalation, because we tend to avoid conflict, and the way we do that is by shying away from stuff. And actually that often it's the patient that doesn't get the best outcome there. And most people who are seeing you on call when you've got a patient problem are usually happy to help you, or should be. So actually part of that is what happens when they're not being done. Rapid escalation is really important, and we often experience says that they don't do that, they just don't do anything. So how we deal with them, how we escalate them is really important as well, but you have to repeat them more often than you think is the usual answer.
Thanks very, very much for that, Ben, and also Richard. I'm conscious that we have about 6 minutes left and we said we would come back to questions. Ian, is there anything in the chat that we need to pick up?
Quite a lot of interesting discussion, but nothing really that's not been covered by how it's played out really. So Andrew was just saying that we're often inconsistent in our approach to IPS in terms of other areas of work. So like getting that balance between emergency care and RTT and cancer targets. Catherine Hepton, who I believe had to leave, she was saying that sharing organisations to see how people compare to each other is really valuable. Nick Holding shared some resources about IPS if you wanted to look at this a little bit more. Erica reminded us that the recording will be shared. Andrew Rochford was interested in whether IPS are more closely adhered to over and above their content. So I don't know if Andrew's still on the line and whether he wants to add any value on that, or I think he might have had to have left. But yeah, Erica made a point about the paper and practice, which I think's a key thing for in terms of Richard's human factors work. You've got your SOP there and then you've got the actual reality there. And I think that's, you know, there's not many hospitals in the country that haven't got an IPS, but what's the reality and what does that look like?
Thanks very much, Ian. I saw Andrew fleetingly appear and then disappear. Let's see if he's still able to come in, because we have a few minutes and it might be worth concluding on that point.
Well, thanks everyone, and welcome, and thank you for a great webinar. So much to talk about, so much to think about. I guess my point was that actually the content of the internal professional standards is less important than the sort of pattern to which it's adhered to. So you know, and it does lend itself to a rung chart, because there may well be special cause effects where, for good reason, IPSs cannot be adhered to. But if you've regularly got, you know, say for example, an IPS may be that, you know, all patients referred to the medical team will be seen within 90 minutes of referral, and actually the run chart shows that they're only ever seen within 3 hours, and you need to go back and have a look at it from that perspective. On a slightly different note, I'd really, just a reflective note really, Richard, I was really interested in the attributional bias perspective, because, and you've talked about the importance of kindness and compassion, which I think we all recognise are key factors and often missing. And I do think there's something for all of us on the call as clinical leaders around the kindness and compassion we offer our ward staff. So we will push people into a full capacity protocol, or you know, making discharge decisions, but actually if things don't work out right for whatever reason, actually it's the ward staff who then pick up the pieces. And I think there needs to be an organisational response, quid pro quo almost, around that. I'd be interested in maybe exploring that in more detail at another date. But thank you again for a great webinar.
Yeah, I'm going to close now. I think thank you for everybody who's attended, and I hope that you found this food for thought really and thought provoking. I think there's so many things to look at on the human factors, not just about internal professional standards, but that just being an example that we could, you can replicate that to many other sort of projects and things that you're considering and doing. I think again, it goes back to just, if we move on to the next slide, please, just about there is access on you know, on our websites and webinars, and we will give you all those links for those. So I think following on from Richard's brilliant piece, we will be moving to bridging that gap between knowing and doing and improve it, and that improvement in practice. And again, I think that goes back to, you know, we're all, you know, we're all competent people. We all know what we want to do. It's about our patient, and it's about balancing that risk, and it's about really examining why hasn't it worked before, what we've done before, how can we do things differently, looking at that risk, looking at, is your SOP aspirational or ideal as we looked at, or is it needs to be achievable? Have we got the right workforce? It's all very well saying, you know, a cardiologist needs to be in ED within 30 minutes. Well, if they're not job planned to do that, well, it's not achievable if they're stuck in the cath lab, for example. So it's about that. I think it's spending that time on that co-design, you know, to get the outputs that you really want to get. So we will be looking at some of those approaches with Nick at our next session. I think, is there another slide? Yeah, so I think again, we'd be really interested to hear from you, you know, what you think would be of benefit for you for the future learning events. I think the Internal Professional Centre was a really good one to start with, but it's what will be meaningful for you. We can't make that assumption for you, and you will all have a different need, I'm sure. So if you could feed that back to us. Again, is that going to be a Menti, Erica? Yeah.
Yeah, we'll leave it on after the meeting concludes, just
Brilliant.
in case people want to come back to this, but absolutely people's feedback would be really helpful. Just means that we can deliver content that absolutely meets your needs.
Yeah.
And Crystal's also just posted the feedback form. So in the same vein, if you could let us have your thoughts on how the session was for you today, it again just means that we can provide useful content over the course of the next 4 months. But thank you very much, everybody, for joining us. I hope you found it very useful and that it'll leave you with things to consider in the next few weeks.